Bismillahirrahmanirrahim. In our previous lecture, in relation to the cell injury, we discussed the abnormal intracellular accumulation of fat. We discussed fatty liver, and today we will discuss abnormal intracellular accumulation of cholesterol, proteins, exogenous and endogenous pigments, and glycogen. We know that the common abnormal intracellular accumulations in the cells occur in the form of deposition of lipids. We have discussed the fatty change. Today we will discuss cholesterol deposition, and we will also discuss abnormal deposition of proteins, abnormal deposition of glycogen, and abnormal deposition of the pigments, which are colored substances. We will discuss pathologic calcification in our next video lecture. We know that cholesterol is an important component of the lipids, and the cholesterol in our body is either derived from the dietary cholesterol, the cholesterol that we take in food, and there is also another way of cholesterol synthesis, which is known as the endogenous synthesis that occurs in the liver and results in the formation of cholesterol. Cholesterol itself is an important component of the cell membranes, membranes of the organelles, nuclear membranes, and cholesterol is also an important component involved in the synthesis of steroid hormones. And when we talk about the lipoproteins, which are the forms in which lipids are carried in the body, and in the physiology we have studied the chylomicrons, VLDL, very low density lipoproteins, intermediate density lipoproteins, low density lipoproteins in the form of LDL, and high density lipoproteins, which are known as the good cholesterol. The LDL is known as the bad cholesterol because it carries cholesterol to the body tissues, and HDL is named as good cholesterol because it carries cholesterol from the body tissues to the liver, from where it is excreted in the form of bile. So the body very tightly controls the synthesis of cholesterol, and normally there is no accumulation of cholesterol in excess. However, in certain conditions, excess cholesterol may get deposited in the body in the form of cholesterol or cholesterol esters, and in this situation the phagocytes, mainly the macrophages, they get overloaded with cholesterol and other lipids like triglycerides. The abnormal deposition of cholesterol in the blood vessels, particularly in the intima and smooth muscle of the blood vessels, particularly the large arteries and medium-sized arteries, is well known, and this abnormal deposition may give rise to coronary artery disease, which are medium-sized arteries, in the form of atherosclerosis, which may give rise to myocardial infarction. Cholesterol deposition abnormally may also lead to cerebral strokes if there is abnormal deposition of cholesterol in the blood vessels, and it is also involved in peripheral vascular diseases. In diabetes, we know that in diabetes what happens, that the body cannot use glucose for energy. So the alternate pathway for the body to use lipids for energy is the conversion of triglycerides into fatty acids, which are then oxidized for energy. So in diabetes there is insulin resistance leads to excess lipolysis, breakdown of triglycerides into fatty acids. And these fatty acids are oxidized for energy. However, when the body cannot utilize glucose in diabetes for energy, there is excess lipolysis and excess fat mobilization, which may lead to the deposition of cholesterol and other lipids in the body. The most important disease in which there is excess cholesterol accumulation in the smooth muscle cells and macrophages in the enchyma of large and medium-sized arteries is atherosclerosis. We will study in detail atherosclerosis when we will discuss the disorders of the blood vessels, in which we will also discuss the arteriosclerosis, atherosclerosis, and arteriolosclerosis that commonly affects the small blood vessels and arterioles. But atherosclerosis is very important, and what happens in atherosclerosis, that cholesterol is deposited in the blood vessels, particularly in the enchyma of the blood vessels, resulting in the formation of atherosclerotic plaques. And these plaques not only may cause narrowing of the blood vessels and reduced blood supply to the tissues like the cardiac myocytes, but also they are very thrombogenic. And most commonly, these atherosclerotic plaques give rise to thrombus formation, which may have fatal uh, effects on the blood supply of the heart and may cause ischemic heart and myocardial infarction. There are certain other conditions which are genetically related, for example, the hereditary hyperlipidemia, also known as the familial hypercholesterolemia. In these conditions, the cholesterol accumulates in the macrophages under the skin, and in this situation, they may form tumor-like structures which are known as the xanthomas. Here, we briefly discuss cholesterol deposition in association with atherosclerosis. We will study atherosclerosis in detail when we will study the disorders of the blood vessels. But here simply I want to say that atherosclerosis is a disorder which is characterized by the injury to the vascular endothelium. Normally, when the endothelium is intact, it expresses anti-adhesion molecules like nitric oxides, which dilates the blood vessels and also inhibit the adhesion of the components of the blood flow to the wall of the blood vessel, the endothelium. But what happens when the endothelium is injured, for example, by hypertension, by toxins of the cigarette smoke and other causes? Here, the anti-adhesion molecules are suppressed. And in comparison, there is overexpression of the adhesion molecules. We know that LDL cholesterol, which is also known as the bad cholesterol, have a high content of cholesterol. And these LDL cholesterols can damage the vascular endothelium. Once the LDL cholesterol is inside the tunica enchyma, which is the innermost layer on which lies the endothelial layer, and outside the entyma there is tunica media, and the outermost is the tunica adventitia. So this is a blood vessel, and here blood is flowing inside. So once the LDL cholesterol or LDL particles, they enter into the entyma of the blood vessel after endothelial injury, they attract the cells of the immune system, particularly the macrophages. The macrophages engulf the LDL particles, and within the macrophages they are oxidized. Now, once the LDL particles are oxidized during this reaction, reactive oxygen species are produced. And we have studied and we know that the reactive species are free radicals. They will induce a state of inflammation and will recruit more and more inflammatory cells. And as a result, the monocytes, which are converted into the active macrophages, they engulf the LDL particles, and if they get excessive deposition of the LDL cholesterol within these macrophages, automatically these macrophages are converted into cells which are known as the foam cells. And when these foam cells, they die and disrupt, what happens that there is fat deposition in the entymal layer of the blood vessel, and this deposition is known as the atherosclerotic plaques, which contain cholesterol and other lipids. And what happens that as the atherosclerosis progresses, the blood vessels become narrowed, and these atherosclerotic plaques are very thrombogenic. They can activate a procoagulant state, and in the face of this procoagulant state there may be thrombus formation, and if this thrombus is detached in the form of an ambulance, and if it is carried in the blood, it has the potential to obstruct smaller arteries and can give rise to the catastrophe of myocardial infarction. In this slide we can see that this is a normal blood vessel. The inner endothelial layer, the entyma, the smooth muscle layer, and the outermost layer is the adventitia. So what happens that when the atherosclerotic plaques are formed within the entyma and smooth muscle layer of the blood vessels, it causes narrowing of the blood vessels. And if the process is progressive, it will lead to accumulation of more and more fats in the vessel wall, and ultimately it can narrow the blood vessels to a limit that there is a deficiency of blood supply or ischemic changes. And moreover, these atherosclerotic plaques are very thrombogenic. They can activate clotting factors and the coagulation mechanisms in the blood, and these clots, if they are detached and carried in the form of an ambulance, they potentially can cause obstruction of the small blood vessels. Here we can see that there is a tear in the vessel wall of the artery, and this is the cholesterol that is deposited, and the macrophages, they attack the VLDL particles and get them oxidized, and if there is excess accumulation of cholesterol and fats within the macrophages, ultimately the macrophages, they die, burst out, releasing the lipid and cholesterol components and forming the atherosclerotic plaques. We will discuss in more detail atherosclerosis when we will study disorders of the blood vessels. Sometimes excess fats are attacked by the macrophages present in the skin layers and may result in the formation of small fat-laden tumor-like projections known as xanthomas. Now, protein accumulation as compared to fat accumulation in the cells is comparatively less common, and there are some pathologic conditions in which protein get accumulated in the cells. Even physiologically, the protein may get accumulated in the cells. For example, in Nephrotic Syndrome, which is a very well-known disorder of the kidney, in which what happens that there is damage to the basement membrane of the nephrons and leakage of the proteins initially in the form of albumin and albuminuria, and in nephrotic syndrome there is proteinuria, there is hypoproteinemia due to protein deficiency. There may be increase in capillary, there may be formation of edema with the release of fluids outside the vessels in case of hypoproteinemia, which decreases the colloidal osmotic pressure, and the nephrotic syndrome which is characterized by edema, proteinuria, hypoproteinemia, hypercholesterolemia, and dyslipidemia. Normally, the albumin is the first protein that will appear in the urine when the nephrons, particularly the basement membrane or the barrier, is damaged. This albumin mostly is reabsorbed in the proximal convoluted tubules and they get accumulated in these cells. However, if there is continued excess proteinuria and the protein exceeds the capability or the ability of the proximal tubular epithelial cells, what will happen that these proteins, which are normally broken down into amino acids and returned to the body, but in excess presence of proteins, they will give rise to the appearance of eosinophilic hyaline cytoplasmic inclusions, particularly in the tubular epithelial cells. Another example of intracellular accumulation of proteins is the condition like multiple myeloma. We know that the plasma cells are derived from the B lymphocytes, and the main function of the plasma cell is to produce antibodies, which are gamma globulins. So, if in multiple myeloma, which is a tumorous condition, and the excess formation of the plasma cells and the excess production of the gamma globulins, immunoglobulins, they get accumulated in these plasma cells and give the formation of Russell bodies. Also, in alcoholic hyaline disease, when there is excess consumption of alcohol by a person, protein may get deposited in the form of eosinophilic inclusions in liver hepatocytes. Additionally, in diseases like Alzheimer's disease, which mainly occur in aged personnel, the neurofibrillary tangles in the form of proteins, they get accumulated in the brain of these patients, and it has got a very important role in the progression of the Alzheimer's disease, and we can also say that this is also an example of the abnormal intracellular accumulation of proteins. Here, as I said, that if small amounts of proteins are filtered into the urine, they get reabsorbed by the tubular epithelial cells, and these proteins are metabolized into the amino acids and returned to the body. But in the conditions of nephrotic syndrome and other kidney diseases, when there is excess excretion of proteins like albumin and other proteins in the urine, the excess accumulation of these proteins by the tubular epithelial cells in the proximal tubules will give rise to the accumulation of the abnormal amounts of proteins in these cells. In the second example, known as the Russell bodies. So, in multiple myeloma, which is a tumor of the involving the bone marrow and blood cells, what happens that the plasma cells, they secrete greater amounts of the immunoglobulins. We know that the plasma cells are derived from the B cells, and they are concerned with the secretion of the antibodies and the important component of the humoral immunity. So, if there is excess production of the gamma globulins, they will appear in the form of eosinophilic inclusions within the plasma cells, and this is also an example of the abnormal accumulation of proteins in the form of Russell bodies. We know that when we take a carbohydrate diet, the available glucose is first utilized for energy. But the excess glucose, in excess to our need, it gets converted into glycogen and stored in the liver and skeletal muscles. Then at the time of need, this glycogen is broken down by glycogenolysis, releasing glucose, and usually that glucose is used for energy in the fasting periods. But in conditions like poorly controlled diabetes mellitus, there is excess accumulation of glycogen in the renal tubular epithelium, cardiac myocytes, and beta cells of the islets of the Langerhans. Because the glucose cannot be used in diabetes mellitus, and excess glucose is converted into glycogen, and the glycogen is stored in the cells of the cardiac myocytes, in the pancreas, and in the renal tubular cells. We will discuss glycogen storage diseases in detail when we will study the metabolic disorders, and in these conditions, in glycogen storage diseases, they are also characterized by accumulation and deposition of excess glycogen in the cells and tissues. Here we can see in this picture the excess amount of glycogen present in the cells. Now, coming to the other abnormal accumulation known as the abnormal pigment accumulations. So, what are pigments? Pigments, they are colored substances, and they may be formed within the body known as the endogenous pigments, or they may be derived from the outside known as the exogenous pigments. In exogenous pigments, carbon may be accumulated in the macrophages of the lungs, alveolar macrophages, and the disease known as the anthracosis. Similarly, the coal dust may get accumulated in the lungs and respiratory tract, and will give rise to the condition as the pneumoconiosis. Similarly, the silica particles may be accumulated in the cells of the respiratory system and will give rise to the disease known as the silicosis. So, out of the endogenous pigments, we will study the hemocydrin, lipoproteins, and the melanine pigments. We know that the red blood cells have a life of 120 days, and after 120 days, these red blood cells are aged red blood cells. They are broken down by the cells of the reticuloendothelial system and are broken down. The same breakdown of red blood cells may be seen in conditions like hemolysis that occurs during the hemorrhage. Now, what happens that when the red blood cells are broken down, the hemoglobin from these red blood cells is released, and the macrophages, which are cells of the immune system, reticuloendothelial system, of the bone marrow, spleen, and liver, they take this hemoglobin and break down the hemoglobin into biliverdin and hemocydrin. Hemocydrin is a colored pigment, and normally we know that the iron is stored in the body in the form of ferritin, mandy, and hemocydrin. So, what is hemocydrin? Hemocydrin consists of aggregates of the ferritin micelles along with the denatured or amorphous proteins and lipids. Normally, hemocydrin accommodation occurs very less, and the iron in the hemocydrin can be recycled and used for the formation of red blood cells, but in certain conditions there may be excess accumulation of the hemocydrin, and this will give rise to the condition known as the hemocydrosis. However, in severe form, when iron is when iron accumulates in the body, particularly it will lead to hemochromatosis, and we all know hemochromatosis is abnormal severe form of iron excess iron deposition in the body, and particularly we see this hemochromatosis in thalassemia patients which are repeatedly given blood transfusions, and if they are not treated with iron chelators, what will happen, that iron will get accumulated and their liver may get damaged uh, uh, with the disease like hemochromatosis, and this hemochromatosis, if it is uncontrolled, it will lead to liver fibrosis, cirrhosis, and ultimately liver failure. In this slide, we can see a slide taken from a brain tumor in which we can see the colored hemocydrin which is deposited in this area. Lipoprotein is actually a wear and tear pigment. We know that as the person age advances, there is continuous continuous exposure of the body cells to free radicals, and free radicals are continually produced, and these free radicals we know that they can cause peroxidation of the lipid bilayers, peroxidation of the lipids. These free radicals can also cause oxidative modification of the nuclear proteins, and they can also degrade the cytoplasmic proteins. But here the lipoprotein pigment is formed when these free radicals cause oxidation of the polyunsaturated lipids of the cellular membranes, cell membrane, nuclear membrane, lysosomal membranes. So what happens, that the result of this oxidation, complexes of lipids with proteins are formed, and they are known as the lipoprotein pigments. In this picture we can see lipoprotein pigments in the cardiac myocytes, a condition which is known as the brown atrophy. And mostly the accumulation of this lipoprotein pigment in the cells doesn't give rise to any pathology. However, we can say that when we see the lipoprotein pigments in excess, we can presume that there is excess free radical injury to the body and cells in the past. So they act as marker of the past free radical injury. The melanine is a pigment in our skin, and this melanine protects us from ultraviolet light. This provides a barrier to ultraviolet light, and this is a sort of protection. The melanine is formed from tyrosine amino acid, which is under the action of the enzyme tyrosinase, and tyrosine is converted into dihydroxyphenylalanine, which is converted into the melanin. This type of reaction mainly occurs in the cells of our skin known as the melanocytes. However, if there is excess melanin production, which may occur, particularly we see this type of melanin accumulation in black people or people who have excessive exposure to sunlight or ultraviolet rays. So as a protective mechanism, the excess melanin formation occurs, and it sometimes the melanin which is normally found by the melanocytes, it may get accumulated in the basal keratinocytes and the macrophages present in the dermal layer of the skin, and they can take the melanin and may give rise to the formation of freckles, which are easily available as hyperpigmented spots in the skin. In this picture, we can see hyperpigmentation and excess melanin accumulation uh, in Addison disease, which is a disease characterized by the adrenal failure. And in this case, we can see melanin accumulation in the skin. A condition is commonly known as the melasma. And this type of situation may be seen in pregnancy and other conditions. Sometimes the melanin may be deficient, and this will give rise to the hypopigmentation. If the condition is genetically inherited, there will be systemic hypopigmentation known as the albinism, and these people should be protected from the damaging effects of the ultraviolet light and sunlight. However, sometimes local hypopigmentation may occur in the form of vitiligo or leukoderma and will give rise to the hypopigmented spots on the skin and discoloration of the or disfiguration of the skin due to deficient presence of the melanin pigments. These conditions may result in vitiligo or hypopigmentation, which is really an autoimmune disorder. So it may be congenital or it may be acquired. Thank you very much.